Hello, welcome to a new tutorial presented by DSA Short TV. In this tutorial, we're going to see thyroid gland pathology. Now, before we start with the thyroid gland pathology, as we initially said in the last tutorial, when you want to start with the pathology of endocrine glands, you must classify them according to hypersecretion and hyposecretion. But before we start with, we're going to see goiter. And this goiter is not going to be neither hypersecretion nor hyposecretion, but we're going to speak about goiter with respect to the macrostructure of the thyroid gland. So, give a general description of goiter. So, general description of goiter is enlargement of thyroid gland, which can be caused by hyperthyroidism, hypothyroidism, or euthyroidism. So, it can be in all the cases, but we said that our main discussion on goiter is with respect to the macrostructure of the thyroid gland. State and explain the types of goiter. You have two types of goiter. We have endemic goiter and we have sporadic goiter. The endemic goiter in more than 10% of the population. So more than 10% of the population, we have endemic goiter. So when we say endemic, it is localized in a particular region. So the word endemic here shows you that it is localized in a particular region. And something that can make the goiter to be localized in a particular region is that that region does not have one of the nutrients necessary for the thyroid gland growth. So you see that patient with endemic goiter will affect more than 10% population. So it is localized to affect much population, and it is related with insulin, with iodine. So iodine is that particular substance which is used for growth of the thyroid gland. So what happens is that with endemic goiter is that at that endemic region there is deficiency in insulin. So you're going to have more than 10% population affected with that goiter, and it's due to deficient insulin. Thyroid gland is large, so the individual will take the best, we have the best of the limited iodine. So what happens is that the thyroid gland is going to enlarge for it to receive most of the iodine. Now you see that the person here in this case can have a goiter but is euthyroid. So he can have a goiter but has a euthyroidism, but not a hypothyroidism. So in this case, you see that you have a deficiency of iodine in a particular region. So your thyroid gland is going to increase to take much more iodine. So now when it increases like that, it compensates and it arrives the normal level of iodine intake. So when arrives the normal level of iodine intake, is going to produce normally the thyroid hormones, and thus this going to say we are going to say that it undergoes euthyroidism. So you can see a patient who has a goiter but he is euthyroid. So number two type of goiter is sporadic goiter. Females and young adult predominant. So here we didn't say particular predominance, we say that it localized in a particular region. With sporadic goiter, we have female and young adult predominance. Sporadic goiter is due to goitrogen such as Brussels sprout, cauliflower, cabbages, which inhibits T3 and T4. So what happens is that you in sporadic goiter, you take the females and young adult are going to take goitrogens like Brussels sprouts, cauliflower, and cabbages. When you take excess cabbages, excess cauliflower, and excess Brussels sprout, cauliflower, these are mainly vegetable, cabbages, cauliflower, Brussels sprouts. So they are going to cause, and they are goitrogens, and they are going to cause decreased T3 and T4 thyroid hormones. When they cause decreased T3 and T4, they are going to cause less of the negative feedback. It's going to cause less of negative feedback to the pituitary gland. So thyroid stimulating hormone is going to be excessively secreted, and so it's going to cause the hyper growth of the thyroid gland. So now the pathogenesis, you see that decreased thyroid hormone is going to cause less negative feedback to the pituitary gland, so increase the thyroid stimulating hormone secretion. So this is going to cause increase in stimulation of thyroid gland and thus thyroid hypertrophy and hyperplasia. NB, alternating cycles of growth and dissolution lead to nodules. So if you want to know if there is a nodule production on the goiter, you need to know if there is alternating cycle of growth and degeneration. So nodules are going to be produced on a gland if there is alternating cycle of degeneration and growth. And this alternating cycle of degeneration and growth mostly occur in when you have chronic inflammations, because this is a main characteristic of chronic inflammation. When you have repair and growth at the end, when you have repair and destruction at the same time. So you see that in cases where you have chronic inflammation of the thyroid gland, that is going to produce nodules. Describe the gross morphology of goiter. So the gross morphology of goiter is that it's going to be enlarged thyroid gland and you have discrete nodules. So goiter, you have enlarged thyroid gland, discrete nodules, and you have glassy texture. The glassy texture is because of the above is caused due to the presence of colloids. So the glassy texture is due to the presence of colloids. So it's going to cause excessive storage of the T3 and T4. So you have enlarged thyroid glands, you have discrete nodules, you have glassy texture, and this glassy texture is due to colloids. So now let's start with hyperthyroidism. So it said that the central point of the disease in endocrine pathology are hypersecretion, hyposecretion. So the hyperthyroidism, let's start with. So hyperthyroidism, increased level of thyroid hormone in being secreted. Now the causes of the hyperthyroidism are going to be here the intermediary causes. You have Graves' disease, you have toxic goiter. Other primary hyperthyroidism causes are thyroid adenoma, you have postpartum thyroiditis, you have aminodiarone toxicity, iodine contrast media. Secondary hyperthyroidism causes, you have tumor ovary and hydatiform mole. So secondary hyperthyroidism has tumor ovary and hydatiform mole. The primary ones are directly going to come from the thyroid. You have thyroid adenoma, postpartum thyroiditis, and aminodiarone toxicity and iodine contrast. The secondary one, you have tumor ovary and hydatiform mole. So now epidemiology, nothing is said on that. You have the consequence. The consequence of the manifestation of hyperthyroidism are going to be heat tolerance. The person is going to have heat tolerance, is going to sweat, is going to have flushed skin, you have weight loss associated with increased appetite. Weight loss is associated with increased appetite in this case. So weight loss associated with increased appetite. You have palpitation, you have tachycardia, you have tremors, you have anxiety, hyperactivity, diarrhea, fine hair. So in order to summarize the hypothyroidism disease, you are going to say it with respect to number 1, the nervous system, number 2, the gastrointestinal system, number 3, the heat control system. So these are the main systems through which you see hyperthyroidism. Now in the nervous system, you have insomnia. The person is insomnia. The person is excitable, and the person is agitated when you have hyperthyroidism. Now with the heat control, you have heat intolerance, you have sweating, and you have flushed skin. You have heat intolerance, sweating, flushed skin. You can have now in gastrointestinal system, you have diarrhea, increased loss of fluids, increased contraction. So now in the cardiovascular system, you have palpitation, you have tachycardia. In the muscular system, you have tremors, and you have also fine hairs. So all these are signs and symptoms of hyperthyroidism. Investigation, you have decreased level of TSH. So in hyperthyroidism, So it depends on the cases. You have different level, decreased level of TSH, elevated T4. Occasionally, patient will have this elevated. So what happens is that with hyperthyroidism, you can have a primary hyperthyroidism and a secondary hyperthyroidism. In a primary hyperthyroidism, when it comes from the thyroid itself, you see that the T3 and the T4 are going to be high, and mostly T3 because T3 is a form which is passing in blood. T4 is a form which is passing in blood, and T3 is a form which is released into the cells. So the T4 is mainly going to be high. So what happens is that other primary thyroid in primary hyperthyroidism, you are going to have this is going to be high and it's going to cause a negative feedback for a decrease in TSH. But in secondary, where you instead have a TSH and adenoma, pituitary adenoma, you see that in this case TSH is going to be high. But this is of less importance because TSH, you say that it is the lowest adenoma which can occur after gonadotrophic adenoma. So the macrostructure, nothing set on that, this nothing set on that. Describe stroma ovarian. Ovarian teratoma composed of thyroid tissue. So in stroma ovary, it's a secondary hyperthyroidism because of stroma ovary. It is you have a teratoma, an ovarian teratoma composed of thyroid tissue, an ovarian teratoma composed of thyroid tissue. So here you're going to have thyroid hormone released from the ovary cells. So from these ovarian teratomas, and you are going to increase the level of the thyroid hormones. Describe hydatiform mole. So proliferation of the trophoblasts that cause excessive production of the chorionic gonadotrophic groupings which has intrinsic TSH-like activity. So you see that this one is not going to increase the level of TSH, but it only has the chorionic gonadotropin has intrinsic TSH-like activity. So you have proliferation of the trophoblasts. So hydatiform mole is going to cause a hyperthyroidism in the mother. So it's going to cause hyperthyroidism in the mother. So proliferation of trophoblasts that causes excessive production of chorionic gonadotropins. So this chorionic gonadotropin has also an intrinsic TSH-like, which is going to increase the thyroid hormone. Now, the difference between hyperthyroidism and hypothyroidism, you're going to see hypothyroidism in the later section. We have with respect to temperature sensitivity, with respect to weight, with respect to gastrointestinal function, with respect to neurologic activity, and with respect to quality of the hairs. Now, the temperature insensitivity is heat intolerant for hyperthyroidism and cold intolerant for hypothyroidism. With respect to weight, you have loss of weight but increased appetite. So you have gain of weight despite decreased appetite. So here you have loss of weight with increased appetite. Here you have gain of weight with decreased appetite. So activity, you have anxious. If the person is anxious, excitable, and is hyperactive with insomnia. So activity, anxious, hyperactive. Here activity, you have depression and sluggish. Gastrointestinal function, you have diarrhea, and here you have constipation. Quality of hair, the quality of hair here are fine, and here they are coarse. So coarse here implies that they are the hair are thick. Here the hair are fine, so the hair are very thin. So start again. Temperature insensitivity, heat intolerant, cold intolerant. Weight, you have weight loss with increased appetite, gain of weight with decreased appetite. Activity, anxious, hyperactive. Depression, sluggish. Gastrointestinal function, you have diarrhea, constipation, and here quality of hair, you have fine, and here is coarse. Now you can also add the cardiovascular activity, which here you have tachycardia, and here you have going to have bradycardia. Here we also have hypotension, here hypertension. Now, Graves' disease. We initially said here above that Graves' disease was one of the cause of hyperthyroidism, and that cause was intermediary cause. We also have thoracic goiter. We have also primary hyperthyroidism causes, secondary hyper. We have already spoken about stroma ovary, where you say it's ovarian teratoma, hydathiform, where you say that it is a trophoblast hyper production, proliferation of trophoblasts in chorionic gonadotroph, which has TSH-like activity. Now, with Graves' disease, you're going to say that it's an intermediate cause. So, Graves' disease here are going to have all the characteristics of hyperthyroidism. So, we have Graves' disease here. Now, disease hyperthyroidism, increased level of thyroid hormone. Now, due to autoimmune disorders. So now the pathophysiology, epidemiology first of the Graves' disease occurred between 20 to 40 years of age. So epidemiology of Graves' disease is between 20 years to 40 years of age. So, and this is also make me think about practinomas. So practinomas was also in females of 20 to 40 years of age. In Graves' disease, you also have 20 to 40 years of age in female predominant. So you have female predominant again who have Graves' disease, like in practinomas. And this can make you think about the relation of prolactin and thyroid hormone. We said that the thyrotropin releasing hormone is releasing both prolactin and thyroid stimulating hormone. So you see that from the epidemiology, you can see a good relationship between prolactin and thyroid hormone, thyroid stimulating hormone, because the thyroid releasing hormone is going to cause both a release of prolactin and it's also going to cause a release of thyroid stimulating hormone. So they are going to occur in pair. So you can think here about of the epidemiology, because said also in prolactinoma that occur between 20 to 40 years of age and in female predominance, but yet they added again a ratio of 7:1. Now, the pathophysiology due to anti-TSH receptor antibody that stimulate the receptors. So you have anti-TSH receptor antibody that stimulate the receptor, resulting in production of T3 and T4. So with Graves' disease, you realize that you are going to have an increased level of TSH antibody. So these antibodies have the same conformation as thyroid stimulating hormone. So what's going to happen is that so this antibody are going to instead stimulate the receptor of thyroid stimulating hormone. So it stimulates the thyrotroph for the production of the thyroid stimulating hormone, and the thyroid stimulating hormone is going to later stimulate the thyroid hormone secretion. Now we have the consequence / the manifestation of the Graves' disease. So the consequence, you have all the signs and symptoms of hyperthyroidism plus exophthalmos plus pretibial myxoedema. So these are the three consequences that you have. You have all the signs of hyperthyroidism we said above. We said heat intolerance, physically. We have hyperactivity. We have diarrhea. We have tachycardia and all the rest. In hyperthyroidism, we have plus exophthalmos plus pretibial myxoedema. So all these are adding in Graves' disease. We have the macro presentation of the gland. Thyroid gland itself is diffusely enlarged but not nodular. So in Graves' disease, the thyroid gland is diffusely enlarged, but it is not nodular. It is not nodular because we initially said that nodular is due to both repair and degeneration, as in case of inflammations. So you realize that in Graves' disease here, it is instead going to be due to antibodies, TSH receptor antibodies. So these antibodies are affecting instead the pituitary gland and not the thyroid gland. So I'm going to cause increased level of TSH, and which is going to cause increased level of thyroid hormones. The micro presentation, you have hyperplastic thyroid follicular epithelial cells can form papillae. So you have hyperplastic. This is because of increased level of TSH causing the hyperplasia of the thyroid gland. Now describe exothermos and pretibial myxedema. Exothermos is protrusion of the eye due to a retroorbital soft tissue infiltrated with lymphocyte edema and increased amount of glucosaminoglycans. May progress even after hyperthyroidism is under control. So you have exothermos, the protrusion. When you have the protrusion of the eyes, so the protrusion of the eyes is also going to be called exothermos. So, and this protrusion of the eye has main causes. So exothermos can easily be retained as protrusion of the eyes. Now this protrusion of the eyes is mainly due to the eyelid not enclosing totally the eye. So what happened is because of infiltrated lymphocyte, and also because of the reduction or the hyperactivity of the body causes the fat of the eyelid to be reduced. So we have pretibial myxedema. The first question to ask ourselves is, what is myxedema? And myxedema is the edema of the intracellular fluid. You need to know that the spaces of the body are divided mostly into the intracellular space and extracellular space. When you have accumulation of fluid in the extracellular space, that's called edema. It's just going to be called edema. And when you have accumulation in the intracellular space, it's going to be called myxedema. So in this case, you have a pretibial myxedema. Now you have scaling and thickening of dermis. So you see that this myxedema is not associated with pitting. So myxedema, here you have scaling and thickening of dermis due to deposition of glycosaminoglycans. So scaling and thickening of dermis, and the tissue have contained more water. No pitting occurs. You see that the characteristic here is no pitting. So we have scaling and thickening of dermis above the pretibial area with no pitting. Give some important points of Graves' disease. Exothermos and pretibial myxedema are specific for Graves' disease. So you have sign of hyperthyroidism plus exothermos and pretibial myxedema in Graves' disease. So the next one that you can see again in hyperthyroidism is toxic/diffuse or multinodular goiter. So this toxic goiter or diffuse multinodular goiter, you have diffuse multinodular toxic. These are all the names of this particular goiter, can also cause hyperthyroidism. Toxic goiter, a goiter that usually has one or more nodules that produce T3 or T4. So in this case, you have a goiter. It's a goiter. So the patient first has goiter. Usually, a goiter that usually has one or more nodules that produce T3 or T4. However, most goiter are not hyperfunctioning. So in normal cases, goiter are even euthyroid. Most goiter are even euthyroid. So this particular goiter is toxic. That's why the name is there, toxic goiter. Because toxic for the body, because it produces excess thyroid hormones. So you have more than nodules. In this case, you have one or more nodules produce thyroid hormone excessively. Now, we have again complication of hyperthyroidism. Now, the complication of hyperthyroidism is going to be the thyroid storm. A thyroid storm is defined as the abrupt onset of severe hyperthyroidism. And the cause of thyroid storm is because of Graves' disease plus increased level of catecholamines due to surgery or acute infections. So thyroid storm Thyroid storm occurs when you have Graves' disease plus increased level of catecholamines. So if somebody has Graves' disease and is suddenly stressed up, he can have a thyroid storm, severe increase in hyperthyroidism. So if you have Graves' disease and you are fearful of something, you can have increased catecholamines and you have the thyroid storm. So the cause of thyroid storm is Graves' disease plus increased level of catecholamines, and that increased level of catecholamines can be due to drugs, can be due to injections, surgery, acute infections. So epidemiology, nothing is said on it. Pathology, nothing is said on it. Now the consequence, you have a rapid hyperthyroidism. So in this case, you have the signs of hyperthyroidism. You have fever, flushing, sweating. These are all the signs of hyperthyroidism. You have agitation, you have marked weakness, you have mental changes, you are severely irritated, you have hyperthermia out of proportion of other findings. So the hyperthermia here is extreme. Even if you are given a cold environment, you remove all your dresses, the person has hyperthermia, he feels excessively heat. Patient can also have tachycardia, atrial fibrillations, and delirium. All these are signs of hyperthyroidism. Now, the peculiar one sign with respect to thyroid storm is this complication, which is cardiac dysarrhythmia and sudden death. Somebody with this excessive acute thyroid hormone secretion is easily going to have cardiac dysarrhythmias, and sudden death is going to occur with thyroid storm if it's not controlled rapidly. Hypothyroidism. So disease, hypothyroidism is low level of thyroid hormone. So now the cause of the hypothyroidism can be a primary hypothyroidism, and these causes, I initially said, these causes are intermediary causes. Now you have primary hypothyroidism and you can have secondary hypothyroidism. So the primary hypothyroidism consists of Hashimoto thyroiditis, iodine deficiency, and we have idiopathic unknown causes. So this Hashimoto thyroiditis has a particular cause, which is the first cause of the hypothyroidism. You have iodine deficiency, you have idiopathic, and you have secondary hypothyroidism due to failure of the pituitary gland to produce TSH. We have the epidemiology, which is not given, the pathophysiology here, which is not given. We have consequences manifestations. We have the weight consequences manifestation, weight gain, cold intolerance. So these are all the consequences of hypothyroidism. It must be memorized by every student. So you have weight gain, you have cold intolerance, cool skin, thinning of hairs. So here in this case you have coarse hairs. In the case of hyperthyroidism, you have fine hairs. You have loss of lateral portion of the eyebrow. The eyebrows are lost laterally, known as the Queen Anne signs. So we have the loss of the lateral portion of the eyebrow, and that sign is the Queen Anne signs. The loss of the lateral portion of the eyebrow is Queen Anne sign. We have the elevated diastolic blood pressure. Here we realize that you see that there is normally supposed to be hypotension, but with hypothyroidism we have elevated, not the systolic one, but the diastolic blood pressure. You have elevated diastolic blood pressure. You have elevated diastolic blood pressure, you have bradycardia, you have congestive heart failure, delayed resection of the deep tendon reflex, the Workman sign. You have delayed relaxation of the deep tendon reflex. So again, we've said the Queen Anne sign. So the Queen Anne sign is loss of lateral portion of the eyebrow. We said again, there's the deep tendon reflex. You have the Workman sign, delayed relaxation. This is because of hypothyroidism. You are inactive, so this is delayed. So you have carpal tunnel syndrome, which can add up to it. So these are other signs and symptoms, but the main one are the one we're speaking about: cold, bradycardia, elevated diastolic pressure, blood pressure, loss of lateral one. These other ones, carpal tunnel, apathy, facial edema, are less involved. We have galactorrhea, constipation, menorrhagia. Now, investigation. Finding in primary hypothyroidism. So if the findings in primary, you have increased level of TSH, so decreased T4 and T3. So you realize that you have decreased T4 and T3, and you have increased level of TSH. You see that what happens is that there is destruction of the thyroid gland. So you have increased TSH to increase the thyroid gland, but there is no response to that increased TSH. Finding in secondary hypothyroidism, you have decreased TSH and decreased T3 and T4. With macro presentation and micro presentation, nothing is yet there because they are not yet the intermediary causes. Now we have two types of hypothyroidism. Again, we have two types of hypothyroidism: cretinism and myxoedema. So this hypothyroidism with all these consequences can exist as cretinism in childhood and as an myxoedema in adulthood, with their intermediary causes, which are Hashimoto thyroiditis, and we can have Hashimoto thyroiditis, iodine deficiency, idiopathy, and secondary hypothyroidism. So let's explain what is cretinism. So cretinism, hypothyroidism occurring in infancy or childhood. So that's when you have cretinism. The cause, now you can have all the causes that you listed above, but here is mainly with respect to the child. So it is iodine deficiency, maternal hypothyroidism before at early stage of pregnancy. So you have iodine deficiency and maternal hypothyroidism at early stage of pregnancy because the fetal thyroid grows after a period of time. You have inborn metabolic errors in fetus that interfere with the normal synthesis of hormone, the thyroid hormone. You have epidemiology, nothing said, also pathophysiology, nothing said. The consequences now for cretinism, with the name, when somebody is said to be a cretin, it implies that you have a mental retardation, mental retardation, severe mental retardation due to impaired development of the brain. When you say tu es un crétin, severe mental retardation to impaired development of the brain. We have skeletal abnormalities. So with cretinism, you can say this mental retardation, severe mental retardation. We have skeletal abnormality, the short stature, like in cases of growth or hormone deficiency. We have coarse facial features and protruding tongue. So coarse facial features and protruding tongue. So you have severe mental retardation. Number one, severe mental retardation. Number two, skeletal abnormalities. Number three, coarse facial feature and protruding tongue. With macro presentation and micro presentation nothing similarly. Now in case of myxoedema, we have hypothyroidism occur during older myxoedema, hypothyroidism occurring during older children and adulthood. So this is myxoedema in older children, and so this is hypothyroidism occurring in older children and adulthood. Now the cause can be primary hypothyroidism or it can be secondary. So in case of primary hypothyroidism, you have Hashimoto thyroiditis, iodine deficiency, and idiopathy. Secondary hypothyroidism, failure of pituitary. Cause of myxoedema, coma. So myxoedema can also result to a complication called myxoedema coma. A precipitating factor is usually present, which may include urinary tract infection or sepsis. So all these are the causes of myxoedema coma. Now, if you want to know myxoedema coma is going to be a complication of myxoedema. So the precipitating factor is usually the cause of this myxoedema coma. When you have initially myxoedema, are going to be the urinary tract infection of sepsis, trauma, and side effects of medication. Epidemiology, more common in female patients. So we need to know again that the thyroid and pathology are much more common in female patients, and because we said initially said in relation with the prolactin level, and prolactin is also more common with female patients and rarely occur in patients younger than 60 years of age. Pathophysiology, now nothing is said on it. You have the consequence, you have signs and symptoms of hypothyroidism, all the signs and symptoms of hypothyroidism that we're speaking above, and you have complication. The complication is myxoedema coma. What is myxoedema coma? Severe complication of hypothyroidism occurring mostly in older patients. When you have urinary tract infection, you have a sepsis, you have trauma, you have side effect of medication. Urinary tract infection, sepsis, trauma, side effect of medication. Hypothyroidism occurring mostly in older patients characterized by altered mental status with or without coma. So you see that normally when you have cretinism, you have severe mental retardation or mental status, you have skeletal abnormalities, and you have a third one which was given here, quas facial feature and protruding tongue. Now, you may or may not have, when you have cretinism, you may or may not have too much signs of hypothyroidism. These are the main signs of cretinism: severe mental retardation, severe skeletal abnormalities, quas facial feature, plus signs of hypothyroidism. Now, in case of myxoedema, you have the signs of hypothyroidism, and in case of myxoedema coma, you have now this addition of mental status impairment plus coma or without coma. So this is myxoedema coma, and this occurs when you have a superimposing infection, the myxoedema, and that superimposing infection, myxoedema, is urinary tract infection, sepsis, trauma, and side effect of medication. Now, Hashimoto thyroiditis. Hashimoto thyroiditis is a cause of the two types of the thyroiditis, mainly the myxoedema is a cause of the two types of hypothyroidism. So now you have a cause now of Hashimoto thyroiditis, which is not this one. This one's an error. So the cause of Hashimoto thyroiditis is genetic, mainly due to autoimmune infections. So you should do mainly due to autoimmune disorders, where you are going to have an autoimmune antibody which is going to be secreted against the thyroid gland. So this is wrong. So autoimmune destruction of thyroid gland resulting in hypothyroidism, you have a cause. Epidemiology, now it is more common still between the females. We have said that Graves' disease was still in females of 20 to 40 years old, but in case of Hashimoto thyroiditis, you have epidemiology of commonly 45 to 60 years, 65-year-olds of age, female to of greater females than in males. And also in goiter, we said that females in toxic goiter, it is females greater than in males, as we've seen above here. So when going back to goiter, so you had thyroid storm and you had also a goiter above here. So Graves' disease, we had goiter, toxic goiter, T3, T4, and that's all right. So thyroid storm also explained here. So coming back to our section, we have Hashimoto thyroiditis commonly between 45 to 65 years of age. Female to male ratio is 10:1 to even 20:1, 10 males and 10 females and 1 male to have the disease, associated with both Down and Turner syndrome, and is most common cause of hypothyroidism and goiter in the United States. So this is the most common. Hashimoto thyroiditis is the most common hypothyroidism and goiter in the United States. So you have pathophysiology, inflammatory disorder, inflammatory immune disorder, and destruction of thyroid gland. So you have the consequence as manifestation. You see that in this case, you are going to have the signs of hypo or hyperthyroidism in short run. With Hashimoto thyroiditis, you have the signs of hyperthyroidism in short run, and then you have the signs of hypothyroidism in long run. So you have signs of hyperthyroidism in short run and signs of hypothyroidism in long run. Now, investigation. High TSH. So you see that here the person is going to have high TSH because there is not enough T thyroid hormone to do a negative feedback on TSH. Anti-thyroid peroxidase and anti-thyroglobulin antibodies are present. So these antibodies are going to cause a destruction. So you have anti-thyroid peroxidase and anti-thyroglobulin antibodies are present in 90% of cases. So now the macrostructure of this, you have the nodular. You see here in this case with Hashimoto thyroiditis, it is nodular. The reason is because you have a chronic inflammation. When you have the release of the autoimmune antibodies, it's going to cause an inflammation of the thyroid gland. So we said that nodular is due to the repair and the destruction of the thyroid gland. So it's going to be pale and vaguely nodular because the chronic inflammation is not going to be so high. Now, in case we say that in case of Graves' disease, you have a diffuse but not nodular one because there is no inflammation of the thyroid gland. So the micropresentation, you have some lymphocytic infiltrations. So you have usually with follicle formation and plasma cells. You also have plasma cells. So this shows a chronic inflammation and oncocytic changes in follicular epithelium. Now, the next part is thyroiditis. Actually, what is thyroiditis? When you only see the name itis at the end, you already imply that this means inflammation. So now it is involved the inflammation of the thyroid gland. Inflammation of thyroid gland is thyroiditis. Now you have already spoken about the Hashimoto thyroiditis, so we are not going to speak about that. Other forms of thyroiditis are acute suppurative thyroiditis and subacute thyroiditis. So you can say acute thyroiditis and subacute thyroiditis. So describe acute suppurative thyroiditis. An important point here is a rare complication of septicemia. So septicemia can really complicate it. So a cause of acute, when you see an acute disease in modern medicine is mostly due to bacterial infection, and the bacterial infection which are mostly seen with acute disease are mostly streptococci and staphylococcus. So you can have a septicemia of acute thyroiditis. You know that this is a bacterial infection. Viral infection are mostly involved with chronic diseases. So here you have rare complication of septicemia. Clinical presentation, you have high fever. It's a thyroiditis. This thyroiditis, you see that a thyroiditis inflammation is going to cause initially the release, a hyperthyroidism, and then later is going to cause a hypothyroidism. So initially the person is going to, when you have acute, it is initial and it's very sudden. So the person is going to suddenly have high fever, is going to have redness of the skin. These are signs of hyperthyroidism. Redness of the skin overlying the thyroid gland, it shows inflammation, and you have thyroid gland tenderness. So acute suppurative thyroiditis is mostly regional. So we have high fever, sign of hyperthyroidism. We have redness of the skin overlying the thyroid gland, and you have thyroid gland tenderness. So you can say signs of hyperthyroidism plus redness of skin overlying the thyroid gland and thyroid gland tenderness. So it's going to show acute suppurative thyroiditis. While in chronic, the thyroid gland tenderness will not be excessive as in case of acute suppurative thyroiditis. So subacute is also called decaverance or granulomatous thyroiditis. So you have a subacute, also called decaverance or granulomatous thyroiditis. Epidemiology occurring between 30 to 50 years of age female. Here they said 45 to 65 in Hashimoto, and in this case of subacute or decadent, they say 30 to 50 in females with to male ratio to still greater. So 3:1 or 5:1. So you can just come and take the ratio here of ages, 3:5. So you have 3:1 and 5:1. So pathogenesis of the subacute thyroiditis. So where does it result from? Often follow a viral infection. So when you have viral infection, you can have a decadent thyroiditis or subacute thyroiditis. So this is associated with HLA-B35 antigen. So you have the HLA-B35 antigen, because this antigen is going to cause is found on the lymphocyte and is going to cause a destruction of the thyroid gland. So the microscopic morphology, you see the lymphocyte and multinucleated giant cells are found. So this is because of the production is going to cause the production of granulomas. So from this, you can already expect that the decadent thyroiditis is going to have nodules present on it. Can be multinodular or uninodular. Clinical presentation: you have neck pain, so it can be localized. So you have fever is signs of hyperthyroidism. You have signs of hyperthyroidism plus neck pain plus thyroid gland tenderness, but the tenderness here is not so much. Now the main difference between acute and subacute one is on time. We see that acute is going to be very sudden, while subacute is going to take a very long period of time for it to be established. Important point: early hyperthyroidism is followed by hypothyroidism phase. So this is because of destruction. All the ways of thyroid hormone are going to occur, and then you're going to have a case of hypothyroidism. Most patients resume normal thyroid function within 8 weeks. So you're going to have a case of hyperthyroidism in the thyroiditis, then a case of hypothyroidism, and later when the subacute acute thyroidism is going away, the patient is going to restore the normal function of thyroid gland. Now the next point is the neoplasm of the thyroid gland. List some features which are suggestive of malignancy. So when you see these features, you are going to say that there is a neoplasm which is present in the thyroid gland. We have solitary nodule. When you see a particular nodule located in a particular area and it is producing a thyroid hormone by itself there, we have solitary nodules. You have young age of patient having hyperthyroidism or hypothyroidism. You have male gender, because this is much more prominent in females. So you have solitary nodules. You have the age of the patient, young age. You have the male gender. You have cold nodules, no radioactive iodine uptake. So you have nodules just like that. Some symptoms of suggestions of malignancy. So these ones are features, particular features suggested for malignancy. You have, when you visualize on a CT scan, you see a solitary nodule, you see the young age of the patient, you see male gender, and you see cold nodules. These are the 4 features, but I'll take first 3 ones: solitary nodules, young age of patient, male gender. Now the symptoms which are suggestive for malignancy is pain. When you have pain at the level of the thyroid gland, it can show a thyroiditis depending on if you have a decadent or viral infection. It can show this. You have, including pains, you have rapid rate of growth, the rapid rate of growth of the thyroid gland, and you have change of voice. These different signs and symptoms shows the suggestive for malignancy. You have pain, you have change of voice, so, and rapid growth of the patient. List the risk factor of thyroid neoplasm. A ratio of radiation of the neck. So the risk factor is radiation of the neck in a particular first decade of life. when you have a radiation of the neck at the first decade of life, is a great risk factor for thyroid neoplasm. How is diagnosis of neoplasm performed? We have three main diagnoses. We have fine needle aspiration in order to visualize the particular cells. We have surgical biopsy in order to visualize the thyroid, the histologic section. We have fine needle aspiration in order to visualize one particular cell and to see the nuclear constituent. We have surgical excision or biopsy in order to find the histologic morphology, and we have nuclear thyroid scan. Give types of thyroid neoplasm. So the types of thyroid neoplasm that you are going to have, papillary carcinoma. Depends on the papillae of the thyroid gland. You have follicular adenoma. An adenoma is a tumor. You have follicular carcinoma. You have medullary carcinoma, and you have anaplastic carcinoma. Follicular adenoma, follicular carcinoma, medullary in the medulla portion. We have papillary carcinoma at the top, at the level of the cortex. We have papillary carcinoma at the level of the cortex. The follicular is inside, which at the level of the colloid. We have the medullary at the level of the intermediary cell, and we have anaplastic carcinoma. So now, in order for you to speak about the carcinoma, we are going to use another diagram different from the diagram we initially used above, and this diagram is just as this. You think of a man having a trunk, a head, the two limbs, the two upper limbs, and the two lower limbs here, and sometimes that man can have a tail, and this tail is going to represent the pathophysiology. Now, the papillary thyroid carcinoma, we need to know at this point is going to be the important point of papillary thyroid carcinoma. Here you are going to have the epidemiology of disease. Here you are going to have the risk factors. Here you are going to have macro/growth and structure of the thyroid and the microstructure of the gland. Important point: papillary thyroid carcinoma has a good prognosis, even with lymph node metastasis. At presentation, cervical lymph node metastasis are common. So here the patient has common cervical lymph node presentation. The tumor is often multifocal. Poor prognosis is associated with the size of the thyroid gland greater than 2.5 cm, patient older than age of 45 years old, and dorsal variant. Now the epidemiology, any age, but usually between 20 to 40 years old, like in grape disease, more than 80% of thyroid neoplasm are diagnosed as papillary thyroid carcinoma. So what you have to note is that the most of the papillary thyroid most of the thyroid neoplasm exists in form of papillary thyroid carcinoma. Most of the thyroid, and these are going to have localized symptoms on the neck, and we say that the symptoms are pain and change in voice. When you have this particular symptom, then you know that it's a thyroid carcinoma. So most of, which is 80% of the thyroid, exists as papillary thyroid carcinoma. The cause is going to be the red proto-oncogene, the mutation of the red proto-oncogene. So we say that in this case of carcinoma, there is the loss of the tumor suppressor gene. When you have the loss of the tumor suppressor, and this is red proto-oncogene is a form of tumor suppressor gene. Red proto-oncogene loss mutation. Now the risk factor is iodine radiation. When you have ionizing radiation at the young decade of your life, where you have variables sometimes encapsulated. So we said that the papillary thyroid carcinoma occurs mostly at the level of the cortex. So this is why you are going to have much more encapsulated thyroid, variable and sometimes encapsulated. Now the microstructure of the gland, often an eye nuclei, that is clear nuclei. So you have the patient is going to have clear nuclei, overlapping nuclei, nuclear groove, pseudo inclusion, somonas, and papillary architecture you are going to have a papillary architecture, a pseudo inclusion, overlapping nuclei, orphan and eye nuclei. All these are seen in papillary thyroid carcinoma and may have follicular growth pattern. The follicular growth pattern are mostly seen in follicular adenoma or follicular carcinoma. But in papillary, papillary is mostly based at the level of the capsule or the cortex of the thyroid gland, and is going to have these eye nuclei, pseudo inclusion, Salmonus bodies, papillary architecture, and all those with a papillary architecture. One of the clear point which is easy to understand. We have follicular adenoma and carcinoma. The important point here, nuclear feature important in distinguishing follicular from papillary thyroid carcinoma. As noted above, papillary thyroid carcinoma can have follicular growth pattern. So we said that initially here that papillary thyroid can have follicular. So in order to distinguish it, you must distinguish it from the nuclear features. Here you said that there is often eye nuclei, overlapping nuclei, nuclear growth with Salmonus bodies. So this one is in bold. Capsular invasion or capsular invasion or blood vessel invasion, distinguishing follicular carcinoma from follicular adenoma. So when you have with follicular carcinoma, you have capsular with a cancer. The cancer, you see that the blood vessel are going to enter the tissue which is involved. But with an adenoma, there you are not going to find blood vessel. So capsular invasion and blood vessel invasion. So follicular adenoma and carcinoma usually are not multifocal, but in this case you said that it is multifocal. Are not multifocal. Prognosis excision is curative for adenoma, and they do not invade metastasis. If follicular is minimally invasive, the prognosis is good. Mutation now for this one is this TSH receptor gene. So in this case it is TSH receptor gene, but in this case what a red proto-oncogene. In this case it is TSH receptor gene. Mutation in TSH receptor or alpha GS lead to activation of CNP pathway. So now here the growth structure is variable. The microstructure, identification of capsular or blood vessel invasion is most important to differentiate between adenoma or carcinoma. And we said it initially, follicular carcinoma has capsule blood vessel invasion. So from here we also have medullary thyroid carcinoma, which is going to affect the medullary portion, and we have anaplastic carcinoma, which is going to affect the important point of anaplastic carcinoma is that it is rapidly growing, so it has a poor prognosis. It has the poorest of the prognosis with these cases. So the tumor usually causes death within 1 year. That is very bad with anaplastic carcinoma. So that's the main point with anaplastic carcinoma. The epidemiology is older patient, 50 years of age. The risk is still the rate in both men and non-men familial carcinoma. And now we are going to see what is men disease. Men is actually the endocrine neoplasm, multiple endocrine neoplasm. So we have macro growth growth structure. We have presentation, pain, dysphagia, and hoarseness of voice. Microstructure, variable cells, including giant cells, spindles, and all that. But one thing you need to mainly note of anaplastic carcinoma is that it has a poorest of the prognosis, and the patient died within 1 year. With medullary carcinoma, it's not of great importance. What you need to know is only the red. Red is mostly the one which is involved with the mutation here. Okay, from here we can say thank you for all the understanding on the thyroid gland, and the next chapter will be involved with the parathyroid gland. Thanks for your kind attention.